pleasure to be here. You're quite a daunting audience, I have to say. You include amongst your number a huge range of skills, professional backgrounds, academic expertise, frontline practice from a variety of disciplines. And I'm hoping that what unites you and what unites us all is an interest in and a passion for the early years. So I'm going to assume that and work on that basis as I talk to you. This quote from Michael Marmot, I think, sums up why we're all here. Nobody's said it better than him. And what I want to do is really look at the challenges and opportunities presented by the early years. And I want to take a kind of place-based, multidisciplinary, strategic commissioning perspective, which I hope works for you as an audience. I've been really lucky in my career to have worked on early years policy for a number of years. And I'd really like to reflect on what we've learnt in the last 25 years or so, that shows my age, and what we as a society are still struggling with. And I'll end by suggesting three areas that I think might be useful to focus on as you go through today's really full agenda. So firstly, I'll unpack this quote from Michael Marmot and just reflect a bit on the evidence. We are learning more and more, as Sally said, about how children develop in the early years. And the fundamental message, though, has been the same for decades. They're absolutely crucial. We now know that 80% of brain development takes place by the age of 3. And there's been a huge upsurge in interest in the role of early attachment between babies and their primary carers and the effects that that has on their social and emotional development and the really long-term effects of that. And I know you'll hear much more about that today. There's now even an all-party parliamentary group promoting early intervention in the first 1,001 days from conception to age 2. And I know you'll hear later on from Claire Rees, who might touch on that campaign. But we've known for a long time that the early years have a fundamental impact on life chances. It was evidenced many years ago by research using the cohort studies, which began in 1958 and then in the 1970s from the UK and overseas, which shows that what happens in the earliest years of life, and particularly the experience of multiple disadvantage, or what we know as risk factors early on, affects the likelihood of us achieving positive outcomes in terms of income, health, mental health, employment, and the risk of turning to crime later. Most significantly, it's clear from these studies that if you experience several disadvantages, they have a compounding and multiplying effect on your likely later outcomes. Children from families suffering multiple problems are most likely to suffer really poor outcomes. It follows that getting support right during pregnancy and through the earliest years can significantly improve outcomes and life chances, particularly if we get that targeting right to support the disadvantaged groups. And many different studies from many different countries have suggested that the return on investment for such early intervention can be very high, with the widely defined benefits exceeding initial costs by several %. It also follows that support for children and families works best when it's joined up as far as possible around their particular circumstances and their needs to tackle the root cause of multiple problems rather than just particular symptoms. It's really well understood, I think, that families with multiple needs benefit most from support which is as seamless as possible and doesn't rely on them navigating our different siloed agencies to get the help they need. The Healthy Child Programme for 0 to 5s takes account of all this evidence and the value of a universal level of support through, for instance, the 0 to 5 checks for all children with more targeted help tailored to the needs of those families facing particular difficulties. And I know other speakers will talk about that in more depth. Since October 2015, the commissioning of public health services for 0 to 5s, including health visiting, has been transferred back to councils and now sits alongside responsibilities for school nursing, children's social care and child protection, early education and childcare, children's centres, special educational needs, housing, and the wider responsibilities that councils have for the well-being of all the people in their place. This diagram illustrates the current statutory responsibilities. It is pretty complex. I'm not expecting you to memorise it. But It doesn't, of course, capture the wider support around the family and all the factors that influence the early years in such important ways. But it does show that almost all the key partners locally are brought together through the Health and Wellbeing Board, and most areas still have a children's trust or partnership arrangements in place. Councils are uniquely placed to bring together partners with a role in supporting the early years and to facilitate really joint decisions about local priorities and to ensure that commissioning decisions are aligned across the different partners. And I have to say that bringing together of public health teams alongside other council functions has given councils an amazing opportunity to understand population data much better and to think widely and strategically about the health and wellbeing of their population. And that fits brilliantly with their wider responsibilities for place. But there are still many challenges. We've learnt a lot about child development in recent years, and we have aligned many of our structures in a way which helps us to join up the support around young families. But as a society, we're still struggling to prioritise early intervention and investment in the early years. There are a number of obvious reasons for this, and I won't dwell on it, but you would expect me to mention money and the funding context. Over the last Parliament, core central government funding to councils fell as a whole by 40% in real terms, and this year councils have faced a further 2.7 billion reduction in revenue support grant. Children's services in particular face a growing gap in funding which will reach 1.9 billion by 2020. And within that overall picture, government funding through the Early Intervention Fund was cut from about 3.2 billion in 2010 to just 1.5 in 2015. The Children's Society have estimated that early intervention funding to councils will fall to just 900 million by 2020, which amounts to a 70% cut overall. And the public health grant, as we know, which is administered by councils, was cut in year by 200 million in November 2015 and will be cut by a further 330 million by 2020. And I haven't even started on the NHS pressures that we're all so aware of, and many of you will know more about than I do. What is clear is that the financial context is not only hard now, it's going to get harder over the next few years. And so all of us as local partners are going to have to make hard decisions. We're going to have to work together better, to be more open to new models of service delivery and working together to make sure that we get absolutely every maximum value out of our collective resource. Within those tight financial constraints, making the right kind of economic case for early intervention becomes even more important. And that's particularly true for any intervention that doesn't directly support one of the statutory responsibilities. So despite very good evidence in principle for investing in the early years and some really good evidence about particularly early interventions, that economic case isn't always easy to make locally. And I think there are several reasons for this. Firstly, the payback period is really long. When economists calculate the benefits to an individual and society from early years interventions, they tend to count them across the whole expected lifetime. They apply a discount rate so that the later years aren't given so much weight as the earlier years of those benefits, but they still add up the benefits from every year of the expected lifetime. And the benefits from improved health, employment, reduced criminality, etc., don't start for up to 15 years or more, although you can, of course, predict them from improved educational outcomes and behaviour during school years. The second challenge that we face is that in public policy terms, the benefits from good early intervention and prevention are shared right across society, and they're shared across agencies and across different Whitehall departments. Health, education, justice, DWP all stand to gain from getting this right. And that means that the good work of health visitors, school nurses, midwives, social workers, voluntary sector supporters and others to help families and young children ultimately improve outcomes which benefit the justice agencies, police, acute hospitals and wider society. So constructing a business case relies on counting those wider benefits rather than direct financial benefits to the people we're asking to make the investment. So that investment becomes an altruistic one, not a straightforward financial one. I really believe that the early years should be everyone's business. And that's true in the sense that most services potentially have an impact on young families. And the benefits over time flow to a really wide range of agencies and society as a whole. But when responsibility and the interest in success is spread very thinly across Whitehall departments, it can be difficult to build a single powerful strategy across the government. And there's no single minister with the brief to improve health and well-being in the early years. Many have an interest, but there's no single person charged with leading that. The third challenge that we face in building a business case, and I think this is a really slippery long-term problem, is that it's extraordinarily difficult to prove that the support you wrap around a family with a young baby is the support that led to good outcomes, or even harder, is the support that prevented bad things happening. And the studies which show a really high return on investment tend to be American, and they tend to apply a single intervention to a tightly defined treatment group, most likely to benefit from that help. And when you look at those interventions which are proven to be most effective and look at the groups they're suitable for, and even if you're really flexible about which outcomes you're seeking to improve, there isn't a suite of interventions which neatly cover the needs of any local population. There's no single right answer in terms of what should be provided in a particular locality based on the evidence as we know it now. I think the recent evaluations of some really high-profile programmes illustrate just how difficult it is to prove that well-intentioned, evidence-based and well-implemented initiatives really deliver the value-added benefits that all the evidence suggests they should. And that's particularly difficult in a country like ours, where we have really well-developed universal services which provide support to any control group. Here, the Do Nothing comparison group actually are really well served by the Healthy Child programme and our network of statutory services which are available to all our citizens. So where does that leave us? I'd like to suggest three areas which I think are worth thinking about today as we grapple with these problems and over the coming years. And those are cost effectiveness and how we get better at measuring that, partnership and working together, and local leadership. We know that cost effectiveness is key. We're all really well versed now in the language of cost effectiveness, in business cases, efficiency plans. And in virtually every area of the country, people are driving continuous improvement in terms of service design and transformation and integration to make sure that we make the best use of all our resources. But I do think we've still got further to go to join up that ever-improving evidence base with the needs of local communities. There are many tools now which can help local areas assess the return on investment of local programmes, and they can be incredibly helpful in understanding the interventions which will be most effective in tackling smoking or particular other outcomes for which there's a strong evidence base. But they can't yet give us a good view across the relative cost effectiveness of interventions which could support a range of improved outcomes and tackle the needs faced by our local populations of young families. Evidence about what works, and I know you'll hear a lot about this today, tends to focus on the impact of particular interventions for particular groups of people. And when you look at the suite of proven interventions, and even if you could afford to buy all of those and provide them in your community, you couldn't be confident that they'd meet the needs of all groups. In fact, we know that they're likely to be ineffective if they're often to a different group than that they've been proven to work for. And our local populations, as you know, are inherently complex and diverse. And one of the lessons from social care that we've learned is that to make the biggest difference to people facing complex issues, you need to personalise the offer to support their individual needs in terms that they recognise. And this problem of targeting the right group is a really tricky one. It takes a huge amount of skill to run a service which people, particularly vulnerable people, want to use, and to provide classes or sessions that they want to turn up to, whilst also making sure that the people who most need that support actually get it. I remember some years ago talking to children's centre managers who had to employ really sensitive strategies in a very skilled way to create parenting sessions which weren't available to everyone. They couldn't allow them to be filled up with assertive, confident mums who arguably didn't need that support, but they needed to be popular. And they needed to be popular enough to avoid falling into the trap of becoming stigmatising, because they were seen as people who were failing in their parenthood. So how do you get that commissioning strategy right? Many of you I know are engaged in this locally, and we see great examples of commissioning strategies that are very sophisticated. But we know that it requires strong analytical expertise, strong needs assessment, really, really good joint working, and we shouldn't underestimate how difficult that is, and expert judgment. I wanted to show you this example of a framework which is developed by Haringey. And what I wanted to draw out isn't the specific interventions which are listed there. Don't try and read them, I realise they're too small. But I wanted to share the background to how and why it was developed. It emerged in discussions between public health, social care and health commissioners and other partners locally to try and agree a strategy on prevention. They, like many of us, found that we each mean different things by terms like prevention and early intervention. The different professions and disciplines each have a different language and a different view of the world. So this framework has grown out of a discussion which helps to present on the vertical axis the different contributions of different services at an individual, community and population level. So the individual level is down the right, community in the middle and population on the left. And then it's cut horizontally with primary or universal services at the bottom, with secondary and then tertiary interventions above it. Now, you will all probably have your own frameworks in your areas, but in Haringey, this is being used to try and have a single conversation about how local support can best meet the whole range of local needs. And we've also taken it to the NHS Prevention Board as the basis to have a multidisciplinary conversation to develop a better understanding about the role that local systems can play in supporting the prevention agenda. So that takes me on to my second area of focus, which is around partnership and working together. We need to recognise, I think, that there's no single perfect answer to the question of how to get early intervention right. Improving our collective efforts in this space requires concerted action and for local areas to pull together to maximise the support available in the earliest years. And that totally relies on strong local partnerships, which take a collective view of commissioning priorities. There is a really complex set of responsibilities in every area, but in the early years of life, those years when arguably it's the very most important to join up services around the needs of young children and their families, responsibilities are still split between many different agencies. I was in South Norfolk a couple of weeks ago, and they've got a really good example of an early help hub which joins up support for their local population. It involves 27 different agencies, including health visitors, children's services, housing, welfare advice, police, and the CCG. And it has a single point of contact for referrals and the public. And the different agencies, the frontline staff, meet 3 times a week to work out who is best placed to meet the need or request that they've received. And it applies to all ages. It's not just early years, so it can account for and support families as well as children. And crucially, staff are positively encouraged to go the extra mile. They've even got an award called Going the Extra Mile to make sure that they are able to help the individual or family in the way that that individual or family need it. And of course, there are very, very many examples of great joint working in the early years. The wish to join up services at the front line has been an aspiration for decades, but we mustn't pretend it's easy. I want to kind of lead on to the third thing that I'm suggesting as a focus for later, and that's the need for good political and managerial leadership. So far, I've really taken a purely policy view of the issues, but I work in the LGA, which is a cross-party political organisation, and I'm privileged to work on behalf of councils which are politically led. And I know that people are very nervous about political decisions. And I've heard anxiety, and I understand the anxiety from health visitors and other professionals that the crucial work that they and you do might not be valued by political leaders. But in a world of constrained resources where almost impossible decisions have to be made about what will be funded and what will not be funded, the role of really good political leadership based on full and honest advice about needs, evidence and resources is really invaluable. Elected councillors, and I think we have a couple in the audience today, are really connected to their local communities, and local democratic processes are essential when you have to make really hard decisions about priorities. I've seen local leaders play a fundamental role in galvanising local partnerships to pull together and to work through really difficult issues because it's the right thing to do. There's no formula, there's no technocratic answer which completely answers the question of where to invest local resources. So we need that process of healthy debate locally and challenge. In our statutory framework, lead members have a clearly defined role in relation to children's services and on health and wellbeing boards. And in many areas, elected members are championing early intervention at the early years. 87% of councillors in a survey recently saw early intervention as a priority for their council. So finally, I do think the early years, we're all really clear that the early years matter more than any other years in our lives. It's in some senses obvious that we should invest more in them, but we mustn't be fooled into thinking that's a no-brainer. Decisions that we face are really complex in a world of very tightly constrained resources, exacting statutory responsibilities and competing priorities. I chose this final slide, not just because it's a helpful reminder of the importance of play in child development. I know you'll talk about lots of other factors that are so important in child development during the day, but also because it illustrates for me the essence of why people are so passionate about the early years. There are few roles and responsibilities where our collective efforts can be captured in moments of joy like this, and it's been something that I've really enjoyed when I've worked on these issues during my career. So even though we haven't yet, I think, got the full evidence base or enough resources to do everything we'd like to do, it really is the right thing to promote the early years and keep building the business case and the political and wider enthusiasm to get our joint support right for young children and their families.